The selective serotonergic reuptake inhibitors, or SSRIs, specifically block the reuptake of serotonin. In early development, fluoxetine or Prozac is or was the most popular SSRI, and SSRIs have developed in the last 15 years to be wide-ranging in terms of their effect on specific parts of the brain and influencing different people in different ways. So SSRIs pose no unique risk of suicide or violence, and the negative side effects are common to SSRIs, but as development of boutique medications get better, so too do the SSRIs and the impact of their side effects. But the bottom line is they work. Lithium is a medication used for bipolar disorders, and I'll skim over that because we have a whole other section in bipolar disorder. Let's look at electroconvulsive therapy, or ECT, which is an effective, in some cases, of severe depression. This is rare that it's used, but it is commonly used in very, very complex cases, and it involves the applying of brief electrical currents to the brain, and it results in temporary seizures, which afterwards, after 6 to 10 outpatient treatments, individuals might have relief of symptoms of severe depression. The side effects are few and include short-term memory loss, uncertain in terms of how ECTs or why they work, but they do and are effective for very, very severe cases. However, once somebody stops having ECT therapy, relapse is common. Psychosocial treatments include cognitive therapy, which address the cognitive errors in thinking that I spoke out earlier, and these include behavioral components, so work with regards to thinking differently about, for example, the beeping of my stove. That stove is not beeping to annoy me and make me mad. That stove is beeping because it's beeping, and it has nothing to do with me. And in terms of my behavioral component, I can make choices about running away, hiding from that beeping, or turning off that beeping, or sitting through it for a few minutes. And of course, the annoyance of the beeping will and did go away. Other therapies include interpersonal psychotherapy, which focus on problematic interpersonal relationships. Psychosocial treatments have outcomes in terms of comparative to medications that are comparable, actually. The outcomes for psychosocial treatments are as powerful as the outcomes for medications. The research around depression does not suggest advantage for combined treatment, but sometimes when treating depression, medications need to start to help somebody be in a place where they can do the work they need to do and the thinking they need to do, the behavioral psychosocial treatment to gain the strategies and skills and the coping mechanisms to overcome the depression. And then that is, in fact, the best strategy one could possibly achieve. In terms of depression, there's a strong connection with suicide and depression. The actual number of suicides might be higher than the official statistics suggest, because sometimes we don't know, or reporting of suicide might be vague. Suicide rates in Canada are highest in Alberta, Quebec, and the Northwest Territories, and lowest in Newfoundland and Labrador. And our First People have extremely high rates of suicide. There are some gender differences in terms of suicide. Males are 4 to 5 times more likely to commit suicides than females. Males are more successful at committing suicide than females, and females attempt suicide more often than do males. In terms of the nature of suicide, there are some risk factors. Depression, of course, and suicide in the family, low serotonin levels, pre-existing psychological disorders, the abuse of alcohol, past suicidal behavior, experience of shameful or humiliating distressors, and publicity about suicide and media coverage about suicide. There are lots of really good programs to help students gain the skills and strategies to help individuals who might be at risk of suicide. In second year, second semester, so next semester in our crisis intervention course, we'll spend some time learning more about crisis intervention as it relates to suicide. But the most important thing to do is to make sure that anybody who's feeling any of these or is at risk or has any feelings or ideas of suicide certainly needs to be supported and referred to the supports and services where help can be given to that individual. So a counselor, a friend, a colleague, anybody who is able to provide support and social supports and referral to expertise is the way to go. In summary, all of our depressive disorders really are sharing the idea of deviations in mood. There are some common biological and psychological vulnerabilities. Depression occurs in children, adults, and the elderly. In terms of onset, maintenance, and treatment, these can be affected by stress and social support. And I encourage you now to take the time to go back to the DSM through the database and explore each of the depressive disorders more closely, to review the content in each section of the DSM that is extensive, and then to also take the time to review the recommended chapter readings and the other content that's placed for you in Blackboard. When you do all of that combined, you will have a good understanding of depression and how that impacts children, youth, and adults.